Now, what happens if we're not positioning this infant correctly? What's going to happen to him? He's going to have hip external rotation. He's going to have negative cranial molding. He's going to have a preferential head turning to one side. He's going to have shoulder retraction. He's going to have delay in motor development. He's going to have a decreased lung and tidal volume, which is going to ultimately affect oxygenation. We're going to have an altered self-image as this infant matures. And then, of course, you know, he may not have the ability to do some of those midline skills that are so important, which will actually bring about a poor self-image for this infant. And he will not be able to necessarily feed himself. It'll be very difficult for him to get a spoon to mouth. May be very difficult for him to hold a bottle. So, you know, these are all things that we have to take into account, because it's not just the musculoskeletal system that this infant has while he's with us, but it's what we send him home with. What we send him home with for his parents to work with. How will we be, how are we, sending this infant home so that, our outcomes are going to be positive, and so that he will, roll over when he should, that he will crawl when he should, that he will walk when he is supposed to. Because remember, our developmental milestones are not being met. And we have had to alter those because of the simple reason that many of our musculoskeletal milestones are not being met. If you take a look at this, what is wrong with this? You saw this picture in one of the other programs that I presented. And I think this picture is just worth a million words in the fact that this is an infant shortly after delivery is admitted to the NICU. And, I often ask, why do we think that this is an appropriate position for our infant? If you take and you look at any medical textbook, there's not really one that condones the fact that we take and put this infant in sort of a 4-point presentation. I guess the only reason that we do that is because we can see everything, Every orifice is visible to us. We can see everything that is going on. It's actually maybe ease of use for us. But it's really not about us. It's really all about the baby and what is happening to him and how we create an environment that is going to be conducive for him for appropriate growth and development. We need to take and look at how we provide him with boundaries. How do we provide him with a containment system? Because if we leave this infant in this position for a long period of time, we're going to have some negative cranial molding, we're going to have definite shoulder retraction, and we're definitely going to have hip abduction. None of these things are easy to work with. They will cost the parents a lot of money when they go home and a lot of dedicated occupational physical therapy time with this infant. Remember, this was not where they wanted to be anyway. They hadn't anticipated that they were going to be in the NICU. They had not anticipated that they were going to have a 23, 24, 28-week infant. They actually had felt that they were going to have a very healthy, normal boy or girl, and that they were going to spend a few days in the hospital and they were going to go home. So we definitely have to take and to work with these parents and work with these infants. When we're taking and we're looking at the things that we can do, let's talk about head position. Infants prefer turning their head to the right. How many of us that are listening today or that are in the workforce are right-handed and that we prefer the right side? Well, many times, there's very few in the unit that are left-handed, so therefore we do everything from the right. We, by doing this, we instigate the fact of possibly a torticollis with this infant, and then of course we instigate the fact that they may have a lateral trunk curvature because of this. We are uncomfortable with turning the infant the different way so that we're going to be working at him from the left. And actually, we owe that to the infant in order to do that. Sometimes you may have to turn the bed a different way. Maybe you're going to work from a different side of the bed. But we actually do need to try to take and to not put on him our preferences, but to try to give him the benefit of both right and left positions or preferences. We know that when we choose one of those preferences, that more than likely we're going to create a deformational plagiocephaly with this infant, which means we're going to have an abnormal head shape from, this positioning. Because remember, we're still moldable. Dolichocephaly is where we have significantly narrowing and elongated. Many of us know this as the preemie head. If you'll notice here, this is our elongated head. It's skinny, it's narrow. The forward seems to be forward somewhat. And this doesn't change just because this infant leaves our unit and goes home. This is going to be with this infant for the rest of his life. You know, the only thing that would let us know that it wasn't due to the fact of how we positioned him in the unit would be that if any of the relatives in the family, you know, had the same shaped head, and this could be, you know, indicated as being genetic. So, you know, we can prevent this. We do not have to send infants home with a preemie head. And all of us have seen the infant that leaves our nursery with the long, you know, elongated head, very narrow, and, you know, a very pronounced forehead. And as I said, this does not go away. Let me tell you a story about someone that I know, and the fact that it was, they had grown up, they were a preemie, and she was going to her junior senior prom. And she had been asked if she'd like to go and have her hair done. And she refused, because her comments were that she had learned to live with the shape of her head, and that if she went to get her hair done, that the stylist would probably try to take it and put her hair up, do something funky with it, and it wasn't going to be what she was used to. And it would only accentuate the fact that she had a preemie head. And so therefore she did not, you know, have the opportunity to do that, which was fine. She was perfectly content with that, but also realized that there is altered self-image all the way through their life when this happens. And we can work with this, and we can eliminate this. It does take a tremendous amount of due diligence in order to do that. Then, of course, we have what's known as positional plagiocephaly. And this is the one where we've got that right-sided preference all the time, and the fact that, you know, we are always having this infant to the right. And this happens predominantly whenever we have our infants in swings or in bouncy seats, or as they go home and they're in the car seat and so forth, because what happens is that we sort of have the flattening of one side of the head. And when that happens, of course, the only way that we're going to be able to correct this is by a helmet. And helmets are not inexpensive. Helmets are very expensive, and we can't just buy one. We've got to usually buy 2 or 3. And this is, you know, a long process with our parents in order to prevent that. You know, sometimes because of the back to sleep program, that is positional, you know, plagiocephaly, so consequently we may have to have a helmet for that. It's a little bit harder for a helmet to correct versus the other types of positional plagiocephaly that present themselves. But we're very fortunate that we do have helmets that come to the rescue, and we can correct most of this.